Hey guys, it's Ryan, and let's pick this up with posterior skeletal crossbite. So, in this example, for this problem, you'd have a narrow palatal vault. So we're no longer talking about dental crossbite where it's lingual tipping of the maxillary teeth. This is like skeletally, you have a narrow palate. And so treatment for this would be you could get away with the expansion lingual arches like the W arch or the quad helix. That would be a slower continuous force, but you can only do that for primary and early mixed dentition patients. Because remember, one of the byproducts was also not just moving the teeth, but also opening the suture. So that would help with a narrow palate and separating the maxilla. Um, the two halves of the maxilla, the two halves of the palate, you'd separate them out. So that could work. Another treatment option that's better for a late mixed dentition patient would be palatal expansion with a palatal expander, and it could be rapid or slow. And we'll talk more about which one you'd pick, which one's better, maybe. And this, no matter what you do, it needs to be completed prior to the end of the growth spurt. So, you know, for boys, it's like on average, 13 it starts, and then 14 it goes to 15, 16, and girls it's a little bit earlier, 11 to 12, 13, 14, something like that. But there's so much variation. That's just a generalization. So, but it needs to be completed prior to the end of the growth spurt for your given patient. So here's my crude drawing of a palatal expander. And again, this is, probably should be in at least a late mixed dentition patient. Um, so let's see. So if we have an older patient, we need heavier forces because the older you get, the more interdigitated the palatine bones are getting, the maxillary bones are getting, and that mid-palatal suture is getting much, much tougher to separate. So a palatal expander uses a jack screw that you turn with like a little key, um, and it's not fun. I'm sorry, I've had two of these, and you can do it rapid or slow, and it pretty much depends on how much you turn the jack screw. So rapid, you get almost half a millimeter of activation, which is also equal to the amount of expansion you get per day. So that's quite a lot. Um, and the activation is the same as the expansion, which makes sense because when the screw is the activating device, the force is immediately transmitted to the teeth and then to the suture. So, before when we were talking about the W arch and stuff, that's more springy and the force is applied lighter and more continuous over time. This is just like you screw it, like it's pushing the teeth immediately apart. So they're immediately feeling that pressure. So it's heavy pressure over over a short duration until the teeth separate. So again, that goes back to our biomechanics stuff. And this is a lot. It's about 10 to 20 pounds of pressure for each of these activations. And it causes microfractures in the interdigitated bone spicules of the palate. So that's pretty. It sounds scary, but it does work. You can also do it in a slow activation. This would be about 1 millimeter per week, so it's a lot less than half a millimeter per day. It's only 2 pounds of pressure, and it keeps the suture intact for the most part. And research has shown that it gives the same long-term after 12 weeks or so, 10 to 12 weeks, the same long-term results with less trauma, obviously because you're going slower. Um, so that's kind of uh, cool to know. And again, we'll be pushing the teeth apart. So palatal expansion for, again, just a summary here. For pre-adolescents, quad helix or W arch. For adolescents, use rapid or slow. Probably slow is better, honestly, palatal expander. This will also, just a side note, tend to extrude posterior teeth and cause anterior open bite. So you want to watch that if the patient's already like a long face um, uh, skeletal discrepancy, you want to watch using a palatal expander. All right, and then just quickly with the excess overjet, um, you treat this with, because overjet is a class 2 presentation, so you treat it with class 2 elastics. And this is opposite from class 3, where you'd have it from forward on top to back on the bottom, and it would pull this upper arch back. It would tip. You could also tip back the maxillary incisors with a removable appliance. So instead of finger springs or Z springs pushing outward, you have a labial bow or something activated to tip the incisors back. All right, so let's talk about anterior open bite. So this is another problem that we mentioned. And then specifically for this orthodontic problem, simple, if this is an oversimplification, simple refers to dental and complex refers to skeletal. All right, so let's talk about simple anterior open bite. So this is, we also talked about posterior crossbite, but mostly simple anterior open bite is so much so due to prolonged thumb sucking habit during childhood. So classic presentation is the flaring of maxillary incisors, the lingual tipping of mandibular incisors, which together would lead to an overjet. There's maxillary constriction due to the increased tone of the buccinator muscle, and that causes posterior crossbite, usually unilateral. And you also get an over eruption of the posterior teeth. And that's because, and then that would cause an open bite. So essentially, the open bite is due to the posterior teeth erupting too much. So it leaves an empty space between the anterior teeth where the thumb was occupying the space. And then treatment, if you're in primary dentition, you just kind of monitor it. And once you get to mixed dentition and you still have an open bite problem, then you need to consider thumb sucking therapy. So that could look like putting a bandage on the child's thumb to remind them not to do it. It could look like a bunch of different kinds of therapies, but the main thing here is that the child needs to want to stop. If they don't want to stop the habit, then there's no point. They'll just bend any appliance you put in their mouth. But if they want to stop, and then you pose this as a helping hand rather than a punishment, then you have a good success rate. So if you do this by age 6 or 7, most changes will resolve spontaneously due to natural soft tissue pressures, which is great. And so this is a picture of an anterior crib, and that's just a metal, thicker metal wire that hangs down. So if the child sticks their thumb in their mouth, they're reminded not to do that by this piece of metal. Okay, and now let's talk about complex anterior open bite. So this is, actually, you know what? Let's stop here. I'll make another video to cover the last couple of topics, and we'll go from there. So thanks for watching, guys. See you in the next video.